Okay, sir. So,
A 30 years old patient with shortness of breath.
okay, sir, I am provided with a chest X-ray frontal projection of a skeletally mature patient. I can see an opacity which is noted in the along the right hemithorax, and it is well defined laterally and ill defined medially. So it's likely that of the mediastinal origin, and I
Good,
can see the hilar vessels through it. So hilum overlay sign is positive. So either it is
good,
anterior or posterior mediastinal. So
good.
keeping in view that I can see the cardiac cilia, it is likely a posterior mediastinal mass lesion. The differentials could include neurogenic tumor or neuroenteric cyst. I would correlate my findings with the history of the patient, compare with any previous CT, X-ray radiograph available, and advise cross-sectional study for further workup.
Okay. You mentioned it's posterior mediastinal mass because of the first point, the right cardiac border can be seen through this lesion. Okay.
Yes, yes,
And it is not, so it is not anterior. And it is
yes.
not middle mediastinum since I can see the hilar vessel hilum overlay sign. Any definitive sign, it's posterior. I want
Sir,
additional.
splaying of the ribs is also caused by this mass.
Excellent. Excellent. Yes.
Yes,
Splaying of the ribs with some rib remodeling. Very good.
yes.
You mentioned positive. Of course, don't forget the negatives. No pulmonary lesions, no other bony lesions,
No.
and. Okay. Now, CT scan of the same patient. I will scroll for you. Okay. Oh, you can scroll?
Yes, sir, I want to scroll.
Okay. I will give you. Okay. You are candidate two.
Yes, sir, I'm
Okay.
connected.
You have the mouth.
Okay, sir. So I'm scrolling from top to bottom, and the mediastinal window CT scan axial contrast enhanced has been provided. So I can appreciate that there is an heterogeneous lesion, which is demonstrated in the right paraspinal region, and it is showing soft tissue intensity, and as well a few fat intensity areas are also noted in it. And okay, so I want to see the density. Okay, so basically it's a soft tissue lesion, and it is also extending into the surrounding neural foramen, and there is neuroforamen extension
Good.
also
Good.
noted. And I will Okay, sir. I will review the bone window and also review it in the sagittal and multi-reformats. And for intraspinal extension, I would advise MRI to look for the
Good.
intraspinal extension and the relation with the spinal cord. So again, this is likely, sir, a tumor of neurogenic origin, and I will refer the patient to the referring physician and convey my findings along with it.
Okay, very good, yeah, boss. Except one point. Did you see the lower cuts?
Okay, sir.
No, I forget. Okay.
Okay, okay,
It's normal. It's normal. It's normal. But
okay,
in the
okay.
exam, please
Yes,
go
I have
to
to
the
see.
last cut. Okay. Don't forget this point. Okay. I'll give you another case. Excellent, yeah, boss. It's a neurogenic tumor because it's first, it's posterior mediastinal. It causing widening of the neural foramen. It causes lateral scalloping of the vertebral body. It causes remodeling of the ribs and the hyperostosis. It's thickened ribs, no rib destruction. It means it's long-standing process. I know it's uncommon. It's uncommon for neurogenic tumors to contain fat, but still it has all criteria of neurogenic origin. Important point mentioned by Dr. Amir is the intraforaminal extension and compression on the thoracic dorsal cord, which necessitates an MRI study to detect or to look for any cord malacia affection by this compression. And of course, convey the finding to the referring clinician. So this is a posterior mediastinal mass. The right cardiac border is seen through, and the heart is anterior structure, so it is not anterior. Hilar vessels is seen through, and the hilar vessel is medial mediastinum, so it is not middle. And the definitive sign, splaying of the lips, widening of the lips with hyperostosis and remodeling. It's definitely posterior mediastinum. From a radiograph only, we suspect a neurogenic tumor. We suspect esophageal duplication cyst, although it's less likely due to lack of continuity with what is the name of this line, my friend?
Sir, thoraco-abdominal line.
No, anatomy. Okay. Azygosophageal line. Azygosophageal line.
Is I guess.
If continuous with this line, most likely it's of esophageal origin, like duplication cyst, like esophageal leiomyoma, or even esophageal carcinoma. Other differential diagnosis of a posterior mediastinal mass may be extramedullary hematopoiesis if there is widening of the ribs, abnormal trabeculation. Also, maybe a hematoma or abscess if a given history supports that, or if there is destruction of the vertebrae. Very good, yeah, boss. Easy case also. Same complaint, 30 years, Disney.
Okay. Sir, I'm provided with a chest X-ray frontal projection of a skeletally mature patient, and in this X-ray, the obvious abnormality I can see is that there is a mild anterior and superior mediastinal widening is noted, and so the cardiac cilia is unremarkable, and there is also widening of the right paratracheal stripe is seen, and rest of the lung fields are grossly unremarkable. The retrocardiac, the below the diaphragm and corners of the film, I would review the corner of the film. They are unremarkable, sir. So it is likely an anterior mediastinal mass lesion. I would correlate my findings with the previous radiograph if available and advise a cross-sectional study for further workup.
Okay, why take it me so rapid? This is anterior mediastinal because of number one, number two, number three. Give me three reasons why you diagnose it as anterior mediastinal.
Sir, it is causing superior mediastinal and anterior mediastinal widening. And again, sir, I could see the
Okay, I see the hilar vessels, hilum overlay sign. This is number
sir, it
four.
is cervicothoracic sign is not positive.
Yes, yes, very good,
It is
very
not
good.
it is not crossing the clavicles, and
It fades out above the clavicle. It fades above. Okay.
yes, yes.
Let's go from down up. Continuity with the left cardiac border. Continuity, inseparable silhouetting of the left cardiac border. The lesion
Okay,
is continuous. This is number one. It means it's anterior structure. I can see the descending thoracic aorta through the lesion, and the descending thoracic aorta is a posterior structure. Okay, so
okay.
again, it suggests this mass, this soft tissue, is an anterior,
Anterior
and
mediastinal.
above, its upper border is fading out of the clavicle on both sides, which means silhouetted above the clavicle or positive cervicothoracic sign. So we have three signs from down upwards. Continuity or inseparable from the left cardiac border, and the cardiac border is anterior structure. I can see the descending thoracic aorta, and this is a posterior mediastinal structure and positive cervicothoracic sign. They like to hear the signs in the exam, like hilum overlay sign and cervicothoracic
Cervicothoracic.
sign. Again, any mediastinal mass, comment on positive or negative.
Okay.
Okay, no differential densities, no interlesional
Okay.
calcifications, and differential diagnosis includes.
Sir, anterior mediastinal, sir, we have a lymphoma, thymoma, and lymphadenopathy, and thymic lesion, germ cell tumor.
Okay, less likely germ cell tumor teratoma due to age group. Very good. And unlikely thyroid. Good.
Thyroid.
And now from CT scan, you can scroll.
Okay, sir, I'm scrolling. I can appreciate that. Okay, sir. Soft tissue intensity, anterior mediastinal lesion is noted, and I cannot see any fat component or any calcification inside it.
Good.
And I would look for other lymphadenopathy, other areas. I can see the I will scroll till the last cut and then okay.
Yes, yes, yes.
Okay. So I
Any
have
lymph nodes?
suspicion. Yes,
Yes,
sir. I
good,
have suspicion of lymph nodes in the lower abdomen as well, and there are also mediastinal lymph nodes noted. One in
good.
the subcranial region, and a few lymph nodes are also noted in the precranial region. And sir, keeping in view the and also in the right paratracheal region, sir. So keeping in view the lymph nodes and this lobulated mass, it's likely a lymphoma, and I would correlate my findings. I would convey my findings to the referring physician and advise histopathological correlation of this and also complete CTs, chest, abdomen, and neck, chest, abdomen, and pelvis
Yes,
to look
staging,
for
good.
any other area. Yes, and in any other areas of involved lymph nodes. In my routine practice, I would also review the lung window and bone window to look for any deposit in them.
Good. It's a lymphoma, and I will add when the soft tissue surrounding the vessels without
Yes.
attenuating its caliber, it is called
Uh,
sign. They like to hear the signs. Soft tissue surrounding the vessels without occluding them. You didn't revise, yeah, boss. Okay. Okay. Floating vessel sign, correct.
Floating vessel sign. Okay.
Yes.
Okay.
Sandwich sign in the abdomen or in the
And I am
hair,
very
floating.
bad in remembering the name of the signs, so
No
that's
problem.
why.
No problem.
Okay.
Take care. You and our friends, they like to hear the signs. Okay.
Okay. Sir.
And any mediastinal mass, any suspected case of lymphoma, please comment, or any suspected TB. Comment on any presence or absence of axillary lymphadenopathy and also neck lymphadenopathy. We have here some neck lymph nodes, correct?
Yes.
Some lymph
Yes.
nodes in the neck. Any mass in the chest, like bronchogenic carcinoma, comment on any presence or absence of supraclavicular lymph nodes. And before going to a bone window, please check rapidly on the bones. Of course, we have here suspected lymph nodes in para-aortic, so I will ask for staging and histopathological correlation. Thank you, boss. Very good cases, except the signs, the name of the
Okay.
signs. Okay.
Okay, sir. Okay.
Okay. Thank you.
Okay. Thank you so much, sir. Thank you so much.
Welcome.
Okay, so I'll ask the next candidate number three to unmute.
Okay.
Candidate three, are you with us?
Yes.
Okay.
Okay. How are you, يا boss?
How are you, doctor? Alhamdulillah.
Alhamdulillah. You can start 35 years old, dyspnea.
I'm presented with a chest X-ray frontal projection for a skeletally mature patient. The striking abnormality is a well-defined opacity seen projected over the superior mediastinum. Its lateral border is seen delineated and well-defined, and its medial border merged with the mediastinum.
Good.
The opacity extends above the clavicle, making a negative cervicothoracic sign,
Excellent.
which denotes it's a posterior mediastinal mass. My
Good.
differential diagnosis includes abscess or osteomyelitis with abscess formation or hematoma, or extramedullary hematopoiesis, but I don't see any bony changes. There is no expansion or prominent trabeculae.
Good.
It also includes neurogenic tumors, including schwannoma or neurofibroma. So I will proceed, I will convey my findings to the referring physician and recommend further cross-sectional imaging, CT or MRI.
Very good, yes, very good. But any rearrange the differential diagnosis. Very good description. Superior mediastinal mass projected over the left upper lung zone or field, having well-defined lateral border, medial border merged with the mediastinum or broad-based to the mediastinum. Its upper border is well-defined above the clavicle, well-defined, so not silhouetted, so negative cervicothoracic sign. Another point here, we add in posterior mediastinal masses no splaying of the underlying ribs because it's a known issue. No bony lesions, no normal trabeculae, no pulmonary lesions, and symmetric breast shadow. It's okay. Differential diagnosis, as you said, but common is common. Neurogenic tumor first,
First,
followed by gastric duplication, or I'm sorry, esophageal duplication cyst. Okay, normal vertebral height unlikely to present abscess or hematoma with absence of history of trauma. Very good, yeah, boss. Now, do you want to ask for control, or I will scroll for you?
I will ask for control, please.
Raise your voice. أيوة. Raise your voice little.
Okay. I'm trying to scroll. I'm
Candidate 3, I'm sorry to interruption, but you are barely audible. Please, can you raise your voice?
Okay. Is this okay now? Can you hear me?
Okay.
Yes, better. Okay.
Okay. I'm presented with chest, CT chest axial cuts. I will proceed till the last cut and give my comment. Sorry, it's lagging.
I will help. Okay.
Okay.
Okay. No problem. Now concentrate this. You stayed a long time without saying any word. This is negative attitude, okay?
Yeah,
You
it was
must
lagging.
speak, talk, no
Okay.
problem.
No.
Talk. Tell the examiner, I'm scrolling from the first till the last cut. In this patient who is complaining of 1, 2, 3,
Okay.
talk. If there is a lag, mention to the examiner, please. If
Okay.
any technical error, mention immediately. And
Okay.
report it after the exam. Okay?
Okay.
Okay. What do you see here?
The CT axial cuts, contrast enhanced CT axial cuts shows confirms the previously noted opacity on the X-ray to be a left superior posterior mediastinal mass, which shows a faint or a little enhancement. There is no underlying erosion or bony changes. And there is a fat plane between it and the esophagus, so it's not invading the esophagus.
Very good.
So the
Not
mass is,
invading or arising from the esophagus. Good.
and the mass is likely non-aggressive mass,
Good.
showing no aggressive features. So it confirms the top diagnosis, which is a neurogenic tumor. It also shows at this level no intraforaminal extension.
Good.
And I will confirm this with MRI. I will confirm my findings to the referring physician.
Okay. You mentioned the smooth lateral scalloping of the vertebra.
No.
You see here?
Yeah.
The vertebral body is bulging to the side, but here
Yes.
it's indented, smooth indentation,
Yes.
reflecting longer period of time and benign nature of this lesion, and
Yes.
solid appearing. It's hypo-enhancing.
Yes.
I may ask you, for example, maybe cyst with dense content. How to differentiate solid from cyst?
I will do HU density, Roy.
Yes, measure the Hounsfield unit. For
Yeah.
example, it's 40.
Soft tissue.
Or maybe near blood density. What to do? You can ask to for pre-contrast study, and remeasure. If the same measurement, it's a cyst. Okay.
Yes.
If it was a lower measurement, for example, and increased, okay, it's enhancing lesion. Very good,
Yes.
Yabos. It's a neurogenic tumor. I'm sorry, just I wanted to explain what's meant by cervicothoracic sign, because some of our colleagues are confused with this sign. It's a very important in the exam. Okay, this is a chest, and this is the, let's say, this is a clavicle. Okay, and this is the anterior mediastinum, and this is the posterior mediastinum. Okay, anterior mediastinum nearly absent above the clavicle, but posterior mediastinum containing significant lung tissue above the clavicle. If the lesion is anterior located, I can't see the border normal. So it fades out. But if the lesion is posterior, okay, the lesion become in contrast, the lesion is soft tissue and the lung is containing air. So the contrast makes the border very well defined. So if I see a very well defined border above the clavicle, it means the lesion in the posterior mediastinum, where there is a numerous lung tissue. This is number one regarding the definition. If it is well defined, it's in the posterior mediastinum. If it is ill-defined, it's anterior mediastinum. What about positive and negative? When I say positive, when I say negative, cervicothoracic sign is considered variant of silhouette sign. What do you mean by silhouette sign? For example, if a lesion is present or opacity is present in the middle loop, what it will cause in the right cardiac border? In definition, silhouette, silhouette, hidden border. I can't see the border. This is called silhouette, okay? So positive silhouette means I can see the border. Here, we can see very well-defined border. It means in the posterior mediastinum, it means negative silhouette or negative cervicothoracic sign. Unlike this case, I can see the border we defined above, no definition above the clavicle. It means it's silhouetted. It lies within area devoid of air in the anterior mediastinum. So silhouetted means positive, positive cervicothoracic sign. I hope you understand this. Okay. Okay, Abbas, the second case. Proceed.
I'm presented with a chest X-ray frontal projection for a
Raise your voice or come closer to the lab. Okay.
for a skeletally mature patient. The striking abnormality is a superior mediastinal widening and thickening of the right paratracheal line. This opacity is seen continuous with the left lateral border of the heart.
Good.
It means that it is anterior mediastinal mass, and also it's not silhouetting the posterior mediastinal structure such as the aortic knuckle.
Very good. And descending aorta, very good.
So it confirms that it is anterior mediastinum. My differential diagnosis includes lymphoma, teratoma, but I can't see any differential dynasties or
Good.
calcifications, and lymphoma.
And thymic tumors, okay.
And thymic tumors. So I convey my findings to the referring physician and proceed with cross-sectional studies such as CT.
Okay, don't forget negatives. No bony lesions could be seen, no pulmonary lesions, symmetric breast shadow, and so on. Don't forget the negatives. Okay, and of course on CT scan. Okay, you can scroll.
Yeah, okay. Request control. So this is a CT, a contrast-enhanced CT chest, axial cuts. It confirms the presence of anterior mediastinal mass. The mass is seen compressing the left brachiocephalic vein and also the aortic arch. The brachiocephalic vein is seen coursing through the mass, giving the floating vessel sign.
Good, good.
Also, there is no destruction for the sternum or invasion to the surrounding structures. I'm scrolling downwards. And there is also minimal left pleural effusion.
Good.
I'm reaching the upper abdominal cuts to search for lymph nodes enlargement.
Or splenomegaly or hepatic focal lesion or adrenal lesions, and comment on all this. And also pericardial, any pericardial thickening, any pleural nodularity, comment on all this. Okay, continue.
So this there is no calcifications and no fat density in the mass. So this keeps the top differential is lymphoma. I
Good.
will convey my findings to the referring physician and recommend a histopathological correlation and biopsy
And the staging CT of the abdominal
and
pelvis.
picture. Yeah.
Good, yeah, boss. And don't forget, please, in my routine practice, I will check on lung window
Lung
and
window.
bone window. And from, by the way, from the radiograph itself, we have the pleural effusion. I forget to comment it.
Oh,
This negatives is important because
yes,
if a significant pleural effusion, it may be pleural metastasis secondary to lymphoma or
yes,
pleural metastasis secondary to invasive thymoma. Both
yes.
lesions send pleural metastasis. So it's
Yes.
important. So don't comment on the positive finding and forget other findings. The last question to you. What if a faint calcification or suspected calcification within this lesion?
I can bring the bone window to make sure that is calcification.
Would what if proved its calcification, especially in the
Okay,
pre-contrast study? Hmm.
okay, it would be my first differential would be a teratoma.
Teratoma. But the patient is old. Any other differential? It will be unreliable in old or يعني
Yes.
improper differential.
Treated lymphoma.
Treated lymphoma. So I want to compare with previous studies and know if
Yes.
there is a previous lymphoma. Good. Any other differential or anything from history you want to ask about? The patient has history of travel.
TB.
I don't hear you يا boss. Raise your voice,
TB.
please.
Tuberculosis.
الله يكرمك.
Tuberculosis.
Okay.
Tuberculosis.
Tuberculosis. Good. But he has history of travel to USA.
Mm.
They helped you.
Yes,
Histoplasmosis.
histoplasmosis.
Okay. In such a case, can you name the pathology? If you are suspecting histoplasmosis, what is the calcified mass in the anterior mediastinum?
No, I don't know.
Okay, no problem, no problem. Anyone? Name the pathology if calcified soft tissue mass in the anterior mediastinum related to histoplasmosis. Good.
Fibrosing mediastinitis.
Yes, good. Fibrosing mediastinitis. Thank you, Abbas. Thank you.
Thank you. Thank you.
Okay.
Thank you.
Okay. The next candidate.
Okay, sir. Next, we have candidate number 4. I have asked her to
Hello.
unmute.
Okay.
Candidate 4, are you with us?
Yes, yes, I'm
Okay.
here.
Okay.
Okay. Proceed, ya boss. Okay, from the start, raise your voice. Okay.
This is the frontal chest radiograph of an adult patient. There is evidence of near total opacification of the left hemithorax with a mediastinal shift to the right side. The visualized upper lobe of the left lung and the right lung appear grossly normal.
Okay.
There is evidence of upward curving of the opacity, suggesting pleural effusion in
Okay.
this curve. I'm not seeing the breast shadow on the right side.
Yes, good.
So I'm suspecting a malignancy in the malignant pleural effusion in this case with a patient with a previous history of breast carcinoma.
Good.
I'm not seeing any evidence of any metastatic nodular lung lesions in the visualized. Okay, small is
Okay.
small nodule. I thought maybe vascular. It can be
Okay.
nodule.
Maybe,
Okay.
maybe.
Small
Okay.
nodular, subtle nodular opacities and some interstitial or increased interstitial opacification also noted.
Good.
So maybe possible lymphangitis carcinomatosa also. Uh, there is a
يعني rather normal interstitial, but some fine
nodules are
nodules with the
there. Fine
suspected
nodules.
history of cancer breast, this will be considered pulmonary nodules. Good. So in this case, comment on pulmonary nodules, comment on the ribs. It's very
Bones. I'm looking for any erosion in the visualized bones. I'm not
good.
able to see any bone erosion. Anyway, I will proceed further with a contrast enhanced CT scan of the thorax.
And
And also we'll do a staging CT of the chest, abdomen, and pelvis.
And
Also.
I'm not good examiner. I want everything. Okay. And correlation with previous
And also
imaging is
pleural, and also the aspiration of the pleural fluid is looked for
excellent.
malignant cell.
Yes, yes. Aspiration is important. Okay. And
For
correlation
malignant.
with previous studies. The patient definitely has previous studies. Okay. Very good, yeah, boss. Okay. No Portuguese. No Portuguese. Okay. Let's continue this study. Do you want control or I will scroll for
Yes,
you?
I will ask control.
Okay.
Yes, I asked.
You have.
Okay. This is the contrast enhanced CT scan of the chest of the same patient. There is evidence of moderate pleural effusion on the left side, and enlarged mediastinal lymph
Good.
nodes,
Good.
pretracheal node, and
Perivascular nodes as well.
right
Good.
hilar, evidence of hilar node on the right side is there, enlarged. Subcarenal node is noted.
Good.
The there is passive collapse of the adjacent visualized lung, and the bony cage appears grossly normal.
It's very important to see the bones while in mediastinal window. Some tricks will be there. Okay. Good.
Anyway, I will look in the bone window to see for
Good.
the
It's
bones, and
important.
also lung
Yes.
window also I will check for the lung nodules. And in the liver, I'm looking for any metastatic nodules which I'm not able to see. Visualized pancreas, spleen appear normal. I will look at the adrenals also specifically for any metastatic deposit.
Very good. MashaAllah. You commented on breast shadow and you forget. Okay. The patient has cancer breast. You didn't give me any comment on breast shadow.
Okay,
Okay.
there is no evidence of adrenal metastasis.
Okay.
The breast shadow,
Yes.
on the right side, I'm not seeing there is evidence of mastectomy.
So it's important even in the presence of mastectomy to comment on the operative bed and comment on the other breast. Don't forget
Okay.
this one. Okay,
Okay.
maybe bilateral breast carcinoma, maybe recurrence in the same site. Very good. And as you mentioned, we have pleural effusion. You comment also on the upper part of the effusion because sometimes we may see some nodularity here. Okay, but till now, you summarize and finalize.
I want to see the lung window so to see for the nodules which I saw in the.
Good, good. Okay. We saw multiple nodules in the lung window. Finalize.
So this is a case of metastatic malignant effusion in a patient with a history of breast carcinoma with multiple lung metastasis and enlarged mediastinal lymph nodes. And the patient has to be referred to the if the patient need restaging of the restaging with the chest
Good.
abdomen pelvis to be referred to the higher center for
And
oncology
and
department and
and
multidisciplinary
thoracentesis. Good. And thoracentesis.
oncology multidisciplinary meeting. And patient need an aspiration of the pleural fluid for confirmation and further
Good.
treatment.
Okay. Another another case, yeah, boss. Pre-employment chest radiography.
Okay, this is the frontal chest radiograph of an adult patient, an asymptomatic adult patient. There is evidence of a well-defined, relatively well-defined opacity, oval opacity in the right, projected over the right hemithorax with the well-defined medial and the superior and inferior border, and the lateral border is not. It appears to be merging with the lateral chest wall. There is
Good.
no evidence of any calcification or fat density within the lesion.
Good.
The adjacent bony cage appear I'm not seeing any erosion of the adjacent rib cage.
However, in my routine practice, I may zoom this area to detect any underlying rib
But
erosions. Very good.
the right this rib I'm not able to trace fully. This one.
If you are suspecting a rib erosion, no problem to comment or to
I'm
ask
not
for
able to
CT. It's
visualize
okay.
the medial
Good.
aspect of the this adjacent rib, upper adjacent rib. But in my routine practice, I will. But I am suspecting some involvement of this adjacent upper rib, and there is no definite evidence of any erosion of the lateral chest wall, bony margin, and no definite soft tissue extension. But anyway, because of the dense bone, I'm not able to see any soft tissue component. The possibilities include lateral chest wall lesion. It is not a lung pulmonary origin. Appears to be a chest wall origin. It could be either originating from the bone or also from the pleura.
Good.
But
Like what?
extrapleural fat, I'm not able to visualize the extrapleural fat. Which could
No need. It's just X-ray. Okay.
It's difficult to see
Okay.
that in the CT. I will also look for that. And as so the possibilities include pleural fibroma, pleural
Good.
lipoma, but lipoma will show low density area.
No, not essentially. Okay. In pleural fibroma, any
Fibroma.
laboratory tests do you want to ask about?
I don't know.
No problem. Anyone? Laboratory test as a paraneoplastic for pleural fibroma.
Maybe a CATH? No.
Okay. Good. Yes. Hypoglycemia is a known associations. Okay. And insulin growth factor. Okay, good. I'll give you now. So this lesion is relatively well defined, broad based to the right lateral chest wall.
Appears to be
Very well.
non-aggressive.
Yes.
So,
Well defined medial border, lateral border is merged with the chest wall
incomplete
with
incomplete border sign suggesting
excellent.
extrapulmonary lesion.
Yes, incomplete border sign. They like to hear the signs. Okay, very good, Yabos. And unremarkable
Proceed
other
with the
study.
proceed with
Okay.
the contrast enhanced CT scan for further evaluation.
Okay, this is a further evaluation. You go. Okay.
I will. I have remote control. Okay. No.
You have the control.
Yes. This is the contrast enhanced CT scan of the same patient. There is evidence of a hypodense.
In my routine practice, I will scroll from the first till the last cut, then I'll give my comment. Okay. You reach the last cut and now come back to the lesion. What do you see?
Okay. I'm not seeing any evidence of any mediastinal
It's
lymph.
okay. Back again to the lesion. It's okay. I just remind you and all other friends to say this phrase. It's important.
Okay. There is evidence of a well-defined hypodense lesion, possibly of fat density.
Good.
Yeah, the right lateral chest wall, without any involvement of the adjacent ribs, and extrapleural fat appears to fat is seen, suggesting it is pleural in origin.
Yes.
It's
extrapulmonary, most likely pleural in origin. So
origin.
it's a classic
lipoma.
Yes, lipoma.
The chest wall lipoma.
Yes. Thank you, ya boss. Thank you. Alhamdulillah, easy case. Okay. Well done, ya boss. Just leave the mouse. Leave the mouse. Leave the mouse.
Yes.
Okay. 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 Stop control.